Phlebotomy Chapter 3, Routine Venipuncture. Blood collection procedure, requisition form. The purpose of a requisition form is patient identification, organization of equipment, collection of appropriate specimens, legal protection, emergency care. The required information on a requisition form is first and last name, date of birth, ID number, accession number, patient sex, location, healthcare provider's name, test requested, date and time of collection, special collection information, special patient information, numbers and type of collection tubes, status of specimen, billing information. Greet the patient. Introduce yourself to begin communication process. Look and listen. Students must disclose that they are a student. Explain the purpose of the visit. Informed consent, verbal or nonverbal. Patient has the right to refuse the procedure. Guilty of assault if patient has the perception that you are ignoring his or her refusal. Cultural diversity can affect patient care and communication. It's important to understand cultural differences. Approach all patients with a smile and friendly tone of voice. Be alert to patient reactions. Do not stereotype. Understand the zone of comfort. Spend additional time explaining procedures and patient instructions. Show respect. Sleeping patients should be awakened gently. Give them time to orient and place. Identification errors and physical injury can result if blood is collected from a sleeping patient. Unconscious patients should be greeted in the same manner as a conscious patient. Nursing personnel or family members can assist with patient ID or handling of the arm during venipuncture. Document the name of the person identifying the patient. Psychiatric units. Patients are often anxious. Patients may feel more comfortable with a primary caregiver or family member present. Blood collection equipment must be placed away from the patient. Physicians and clergy members that are present with the patient return at another time unless the request is stat or timed. Explain the situation for stat or timed collections and request permissions to perform the procedure. Family and visitors may be present with the patient. Greet them in the same manner as the patient. Give them the option to step outside. They can sometimes be helpful in the case of pediatric or apprehensive patients. Unavailable patient. You should attempt to locate the patient by checking with nursing personnel. May be possible to collect blood from the area the patient is located. However, if that's not possible, the nurse must be notified and the test rescheduled. Document this. Identifying the patient is the most important step in the venipuncture procedure. 2 identifiers are required by the College of American Pathologists and the Joint Commission. The primary identifier is the patient's ID band. Always compare with the requisition form. Must be worn by the patient on the wrist of older children and adults and the ankles of newborns. Do not trust room and bed signs. Missing ID bands are a problem. Second identifier. Have the patients state full name. Do not ask if they are the patient you're looking for. All information on wrist ID band must match the information on the requisition form and the patient's verbal information. Barcode technology. Handheld personal digital assistant. Scan the ID band. Interfaced with laboratory information system to specify tests and collection equipment. Collect blood. Scan ID band a second time to print labels at the bedside. Radio frequency identification uses radio waves to transmit data for patient ID and tracking. Missing ID band. Patients cannot have their blood drawn. ID band must be reapplied if applicable. Name of person identifying the patient should be documented. Sign the requisition form. Outpatient identification. Primary identifier. Have patient state full name. Second identifier. Ask additional information like the date of birth, spell name, Compare unique data with the requisition form. The Clinical and Laboratory Standards Institute, or CLSI, requires a caregiver or family member to provide information on patient's behalf before drawing the specimen. Document the name of the verifier. Drug testing might require photo ID. Unidentified Emergency Department patients. AABB requires patient to be positively identified with a temporary number attached to the body. Tentative name must be placed on all requisition forms. Commercial blood bank system. Place additional stickers from ID band on the specimen, requisition form, and units of blood. Identification of young cognitively impaired patients or those who can't speak the language. Ask the nurse, relative, or friend to identify the patient. Document the verifier. Discrepancies must be resolved before collection of specimen. Prepare the patient. Reassure the patient. Explain the procedure. Do not explain the test. Do not say procedure is painless. Verify pre-test preparation. Pre-examination variables occur before the testing of the specimen. Variables include diet, posture, exercise, stress, alcohol, smoking, time of day, altitude, medications. Position the patient. Convenient and safe. Support the site. Place opposite fist under elbow. Place arm at downward angle to prevent reflux. Safety. Patient is sitting or lying down. Patients should remove objects from the mouth. Be alert for syncope. Never draw patients who are in a standing position. Select equipment. Place all supplies close to the patient. Do not place blood collection tray on the bed or on the eating table. Place the tubes in correct order for specimen collection. Do not pre-assemble collection devices before patient identification. Hand hygiene is important in preventing healthcare-associated infections. Sanitize your hands and apply clean gloves in front of patient. Pull the gloves over the cuffs of protective clothing. Sanitize hands between patients. Change the gloves between patients. Apply the tourniquet. Vein location. Increases amount of available blood. Can alter some test results. It increases the ratio of cellular elements to plasma and can cause hemolysis. Should never be left on for longer than 1 minute. Never apply the tourniquet on the arm on the same side as in mastectomy. A tourniquet should be applied 3 to 4 inches above the collection site. Avoid or cover arms with skin conditions. Avoid arms on the side of a mastectomy. Use a blood pressure cuff if necessary. Should be flat against the arm. Too tight can cause petechiae, blanching of the skin, and inability to feel radial pulse. Length of tourniquet application. The maximum time is 1 minute. Apply to the site for site selection. Release for 2 minutes, and then reapply. Release once you have achieved blood flow. Hemoconcentration. Concentration of analytes in the veins leads to biochemical changes in the trapped blood, commonly caused by prolonged tourniquet application. Other causes of hemoconcentration are excessive squeezing, probing a site, long-term IV therapy, sclerosed or occluded veins, vigorous fist clenching. Tests affected by hemoconcentration: albumin, ammonia, bilirubin, calcium, cholesterol, coagulation factors, enzymes, iron, lactic acid, lipids, potassium, red blood cell count, and total protein. Major veins. The preferred site is the antecubital fossa. It contains the median cubital, cephalic, median cephalic, and median basilic veins. H-shaped and M-shaped patterns. 70% population has H-shaped. The median cubital vein is the vein of choice, large and well anchored, closer to the surface, more isolated from other structures, least painful because there are fewer nerve endings. The cephalic vein is located on the thumb side of the arm. It's the second site of choice. It's more difficult to locate and it has a tendency to move, but it may be prominent in larger patients. The basilic vein is located on the inner edge of the arm. It's the third choice for venipuncture. The CLSI recommends using only as a last resort. It's the least firmly anchored and may roll. It's near the brachial artery and median nerve. A hematoma formation is more likely with this vein. Consider using a syringe for more control. Always locate the brachial pulse before accessing the basilic vein. Hand veins require winged blood collection set or syringe with a smaller needle. Do not use the veins on the sides of the wrist or above the thumb. Do not use the veins on the underside of the wrist. Locate the vein, apply the tourniquet, have the patient clench their fist, but don't pump. Pumping can cause hemoconcentration and is only acceptable for blood donations. Palpation. Feeling is more important than sight. Probe with index finger of non-dominant hand. Do not use the thumb because it has a pulse. Push, don't stroke, vertically and horizontally. Determine size, depth, and direction. Remember, veins are spongy and resilient. Tendons are rigid. Arteries have a pulse. Select a vein that is easily palpated. Visual references are helpful. Mole, freckle, or skin crease. Placing an alcohol pad on the patient's arm below the venipuncture site is helpful. Check both arms. Listen to the patient's suggestions of previously successful areas. Massaging the patient's arm upward briefly, hanging the patient's arm down, or applying heat to the site for 3 to 5 minutes all help enhance vein prominence. Transilluminator. Wrist and hands. Apply tourniquet to forearm. Consider a small needle, syringe, or winged blood collection set. The CLSI standard is to avoid veins from the underside of the wrist. Puncture of the radial or ulnar nerve or artery may occur. Can cause permanent nerve damage and inability to open and close the hand. Feet veins require healthcare provider approval, are more susceptible to infection, tissue necrosis, and thrombi. Avoid in patients with diabetes, cardiac problems, coagulation disorders. Sites to avoid. Certain sites must be avoided due to the possibility of decreased blood flow, infection, hemolysis, or specimen contamination. Specimens contaminated affects specimen integrity. Incorrect blood collection techniques that can cause contamination. Blood collected from edematous areas, hematomas, arms containing an IV, sites contaminated with alcohol or iodine, infected sites, anticoagulant carryover between tubes. Do not draw from sclerosed, occluded, or thrombosed veins. Hematomas, edematous sites, burned or scarred areas, same side as a mastectomy, arm with IV, heparin or saline locks, arm with cannula or fistula. Damaged veins, numerous venipuncture sites or contain thrombi, feel hard or sclerosed, may be occluded and have impaired circulation. Patients on chemotherapy, chronically ill patients, and IV drug users. Cyanotic areas. Hematoma, blood accumulation in the tissues surrounding a vein. Painful to patient. Collection of old hemolyzed blood. Collect blood below the hematoma. Edema is excess tissue fluid, not recommended for blood collection. It causes are heart failure, renal failure, inflammation or infection, and IV fluid infiltration. Burned, scarred, or tattooed areas shouldn't be sites for blood collection. Veins are difficult to palpate and penetrate. Risk of infection, patient discomfort, and possible complications. Mastectomy. Blood should not be collected on the same side as a mastectomy. Erroneous test results and harmful to patient. Lymphostasis. Increased lymphocytes. Increased waste products. Patient danger. Lymphedema. Infection. Consult healthcare provider for patients with double mastectomies. Possibly perform finger puncture. Do not collect capillary blood on the same side as a mastectomy without healthcare provider documented permission. Obesity. Obese patients may have deep and difficult to palpate veins. Median cubital vein may not be palpable. Check for cephalic vein. Easier to palpate and is more prominent. Blood pressure cuff may work better as opposed to a tourniquet. Avoid probing. Use syringe with a 1 1/2 inch needle. IV tubing. Ideally, use the other arm. If there is an IV in both arms, finger puncture is preferred. Site selection below infusion site. Caregiver turns off IV for 2 minutes. Preferably use a different vein. Avoid drawing blood at the same time. Dye for radiological procedure or blood components are being infused. Heparin and saline locks can be left in a vein for up to 48 hours to provide means of administering medications and obtaining blood specimens. Must be flushed with heparin or saline. Discard first 5 milliliters of blood. Only specially trained personnel are authorized to draw blood. Renal dialysis patients. Most common is a permanent artery or vein connection, AV fistula. Visible under the skin. Uses a looped artificial tubing implanted under the skin. Must avoid this arm. Possibility of infection. Only specifically trained personnel are authorized to draw blood from a fistula, graft, or catheter. Be alert for the presence of a fistula or cannula in dialysis patients before applying the tourniquet. Cleanse the site using a 70% isopropyl alcohol pad using a back and forth motion 2 to 3 inches in diameter. Allow to air dry 30 to 60 seconds will give maximum bacteriostatic action. Avoid wiping off with gauze. Failure to let alcohol dry causes stinging sensation for the patient and hemolysis of specimen. Blood cultures. Povidone iodine, tincture of iodine, chlorhexidine gluconate. Legal blood alcohol level test. Do not cleanse the site with alcohol. Soap and water are recommended. Iodine or benzalkonium chloride or zephyrin chloride may be acceptable. Assemble equipment while alcohol is drying. Screw the stopper puncturing end of the needle into the holder. Insert first collection tube into the holder. Advance tubes only to mark on holder. Make sure you have extra tubes handy. Place assembled equipment within easy reach of non-dominant hand. Reapply tourniquet. Confirm puncture site. Cleansed glove palpating finger if necessary. Before entry into the vein, remove the needle's plastic cap. Visually examine the point of the needle for any defects. If defects are present, remove and discard the needle and obtain a new one. Position the needle for entry into the vein, bevel up. Holder placement. Place the holder in dominant hand. Place thumb on top, fingers underneath. After insertion, fingers can be braced on patient's arm. Pull skin taut. Holding the ETS holder in the position used for injections prevents threading into the vein and bracing the hand during exchange of tube. Anchor the selected vein. Place thumb of non-dominant hand 1 to 2 inches below the site. Place fingers on back of arm. Do not anchor above and below the site with the thumb and index finger. Possible accidental self-puncture. Insert the needle, bevel up, 15 to 30 degree angle, in a quick, smooth movement. Resistance lessens when the needle enters the vein. Non-dominant hand can be used after vein is entered. Use flared ends of holder and the thumb of the non-dominant hand to advance the tube. Once blood flows, patient may release fist. Brace the holder against the patient's arm. Gently twist tubes on and off the needle. Mix tubes as they are removed from the needle. This can be done before the next tube is inserted. Remove and mix the last tube before removing the needle. Blood may drip from the needle. Remove the tourniquet if still applied. Failure to remove can cause a hematoma. Withdraw the needle and apply pressure to the gauze. Capable patients can apply pressure. You must apply pressure if the patient is not able. Do not apply pressure while the needle is still in the vein. Instruct the patient to avoid using this arm to carry heavy objects for 1 hour. Remove the bandage after 15 minutes. Arm should be raised in an outstretched position. Do not bend at the elbow. Pressure must be applied until bleeding stops. Immediately activate needle safety device. Dispose in a conveniently located sharps container. Never bend, cut, or recap needle. Label tube before leaving the patient. Less chance of tubes being mixed up. Use a pen or use computer-generated labels. Confirm information on pre-printed labels. Verify correct labeling with the patient. Get a third identifier. Information needed on label. Patient's first and last name, patient's ID number or date of birth, date and time of collection, collector's initials, additional information, blood bank identification. Bandage the patient's arm. Examine the patient's arm to ensure bleeding has stopped. Bleeding should stop within 5 minutes. Paper tape should be used for patients with allergies to adhesive bandages. Self-adhering bandage can be used to apply additional pressure, such as Coban. Avoid carrying heavy objects for a minimum of 1 hour. Remove bandage after 15 minutes. Patients on anticoagulant therapy may need additional pressure applied. 5 minutes. Do not leave the patient until bleeding has stopped. Complications related to patients on anticoagulant, aspirin, or herb therapy. Accidental arterial puncture. You must apply pressure for 10 minutes. Allergic reaction to adhesive. Bandages are not recommended for children under the age of 2. Do not open bandages ahead of time. Place used supplies in biohazard containers. Remove gloves. Sanitize hands before leaving the area. Thank the patient. Return the bed rails to their original position. Deliver specimens to the laboratory as soon as possible. Use designated biohazard containers. Securely attach the requisition form with the specimen. Use a pneumatic tube system. Wrap specimen. Verify tube has been sent before leaving the area. Common protocols. Separation of plasma or serum from the cells. Correct storage temperature. Protection from exposure to light. Gel separation tubes stored in upright position. Separate serum and plasma from the cells within 2 hours of collection. Hemolysis increases potassium values. Cellular metabolism decreases glucose levels. Coagulation specimens for APTT can remain at room temperature for 4 hours. If the patient is on unfractionated heparin, the plasma must be removed from the cells within 1 hour and test within 4 hours. PT specimens are stable for 24 hours at room temperature. Blood smears from EDTA tubes should be made within 1 hour of collection. Specimen can be refrigerated for up to 4 hours. Using a syringe. Procedure is the same as when using ETS. Withdraw blood from vein slowly by pulling back on the plunger of the syringe. Use free hand to anchor the vein. When patient vein is entered, blood appears in the hub of the needle. Pulling the plunger back too fast will cause the walls of the vein to collapse. Pulling the plunger back too slowly may cause the blood to begin to clot while it is in the syringe. Blood should be added to anticoagulated tubes immediately after blood draw. Use a blood transfer device to fill the tubes using the correct order of draw. Allow tubes to fill according to the vacuum in the tube. Pushing on the plunger when filling the tubes can hemolyze the red blood cells or cause the tube stopper to pop off. Aerosol spray. Do not lay the syringe aside to complete the venipuncture procedure before transferring the blood. Using a winged blood collection set. Used for difficult venipunctures and is often less painful to patients. Angle of 10 to 15 degrees needle insertion. Wings upward when inserting the needle. Blood appears in the tubing with successful entry into the vein. Collect blood into evacuated tubes or a syringe. Coagulation tests. Discard tube used when coagulation tube is first or only tube collected. Prime the tubing. Use partial fill evacuated tubes when using a 23 gauge needle. Prevents hemolysis. Position tubes downward. If a syringe is used, use a blood transfer device. Fill using the correct order of draw. Use extreme care when disposing of winged blood collection set. Activate the safety device on the needle set. Always hold by the wings and not by the tubing. Chapter 3 from the book, Venipuncture Techniques. Key terms. Antecubital fossa, the indentation of the mid-arm opposite the elbow, location of the large veins used in phlebotomy. Barcodes, computer identification system. Basilic vein, the vein located on the underside of the arm near the elbow bone. The cephalic vein, the vein located on the thumb side of the arm. Diastolic pressure, the bottom number of a blood pressure reading. Hematoma, discoloration of the skin produced by leakage of blood into the tissue. Hemoconcentration, increase in the ratio of formed elements to plasma. Hemolysis, destruction of red blood cells. ID band, bracelet worn by patients that contains specific identification information. Informed consent, patient's right to know the method and risks before agreeing to treatment. Mastectomy, removal of a breast. Median cubital vein, vein located in the center of the antecubital fossa. Palpation, examination by touch. Petechiae, small red spots appearing on the skin. Requisition form, an examination request from detailing orders for patient testing and identification. Stat, immediately. Syncope, fainting. Thrombi, clot formed on the inner wall of a vein. Taut, pulling tightly or without slack. Of the veins located in the antecubital fossa area, the median cubital is the vein of choice for venipuncture because it is large and tends not to move when a needle is inserted. It is the median or center of the antecubital fossa. It is often closer to the surface of the skin, isolated from underlying structures, and the least painful to puncture because there are fewer nerve endings in this area. Because the median cubital fossa overlies the bicipital aponeurosis, a fibrous membrane that provides protection to underlying structures such as nerves and arteries, there is also less chance of nerve injury or accidental artery puncture. The cephalic vein, located on the thumb side of the arm or the lateral area of the antecubital fossa, is usually more difficult to locate except
possibly in larger patients, and has more tendencies to move. The cephalic vein should be the second choice of the median cubital vein is inaccessible in both arms. Avoid the most lateral aspect of the cephalic vein to prevent accidental injury to the lateral cutaneous nerve. The basilic vein is located on the inner medial edge of the antecubital fossa near the median nerve and brachial artery. The basilic vein should be used as the last choice because the median nerve or median cutaneous nerve and brachial artery are close to it, increasing the risk of injury. The basilic vein is the least firmly anchored, therefore it has a tendency to roll, as well as a high likelihood of hematoma formation. Take extreme care to avoid accidentally puncturing the brachial artery. 2 routine steps in the venipuncture procedure aid in locating a suitable vein: applying a tourniquet and asking the patient to make a fist. The difference in vein prominence before and after these procedures is usually remarkable, making the veins easier to locate and puncture. However, you should not permit the patient to clench or pump his or her fist continuously because it will result in hemoconcentration and alter some test results. Turning a patient's arm slightly helps you distinguish veins from other structures. Select a vein that is easily palpated and large enough to support good blood flow. It is often helpful to find a visual reference for the selected vein, such as its location near a mole, freckle, or skin crease, to assist you in relocating the vein after you have cleansed the site. Other techniques to enhance the prominence of veins include massaging the patient's arm upward from the wrist to the elbow, briefly hanging the patient's arm down, applying heat to the site for 3 to 5 minutes. Avoid collecting blood from edematous areas, veins with hematomas, arms containing an IV, sites contaminated with alcohol or iodine, infected sites, and anticoagulant carryover between tubes. Veins that contain thrombi or that have been subjected to numerous venipunctures often feel hard or sclerosed, and you should avoid them because they may be blocked or occluded and may have impaired circulation that can cause invalid results. The presence of a hematoma indicates that blood has accumulated in the tissue surrounding a vein. Puncturing into a hematoma not only is painful for the patient, but also results in the collection of old, hemolyzed blood from the hematoma, rather than circulating venous blood that is representative of the patient's current condition. When you must use a vein containing a hematoma, collect the blood below the hematoma to ensure sampling of free-flowing blood. Drawing from areas containing excess tissue fluid or edema also is not recommended because the specimen will be contaminated with tissue fluid. Edema may be caused by heart failure, renal failure, inflammation, or infection. Edema also may be caused by IV fluid infiltrating into the surrounding tissue. Areas that are burned and scarred extensively, including fresh or inflamed tattoos, are more susceptible to infection. Healed areas that are burned and scarred also have decreased circulation and can yield inaccurate test results. Veins in these areas are difficult to palpate and penetrate. The CLSI recommends avoiding inflamed or new tattoos because of the risk of infection, patient discomfort, and possible complications. Applying a tourniquet to or drawing blood from an arm located on the same side of the body as a mastectomy can be harmful to the patient and has the potential to produce erroneous test results. Removal of lymph nodes in the mastectomy procedure interferes with the flow of lymph fluid or lymphostasis and increases the blood level of lymphocytes and waste products normally contained in the lymph fluid. Patients are in danger of developing lymphedema in the affected area, and this can be increased by the application of a tourniquet. Because the lymph nodes have been removed, the protective functions of the lymphatic system also are lost, making the area more prone to infection. For these reasons, you should draw blood from the other arm. In the case of a patient with a double mastectomy, you should consult the physician as to an appropriate site for the draw. it may be possible to perform the tests from a finger puncture, but only with the physician's permission. Veins on obese patients are often deep and difficult to palpate. First, check the antecubital area of both arms for a median cubital vein. When a median cubital vein is not palpable, next check for cephalic vein. Often, the cephalic vein is more prominent and easier to palpate. A blood pressure cuff may work better as a tourniquet when a typical tourniquet is too short. Another option is to use a bariatric tourniquet or a longer tourniquet. After needle insertion, it is important to avoid probing to find the vein because that can be painful to the patient and cause hemolysis by destroying red blood cells that can alter test results. Using a syringe with a 1 1/2 inch needle may offer more control. Chapter 3 Review Questions. 1. The most important step in the venipuncture procedure is identifying the patient. 2. The minimum number of patient identifiers required by the Joint Commission is 4. 3. To avoid interference with test results, the maximum time that a tourniquet can remain on the patient's arm is 1 minute. 4. To prevent rolling veins, the venipuncture step of primary importance is anchoring the vein while inserting the needle. 5. You should not use an arm with an IV running, an arm with a fistula, or collect blood from a hematoma during venipuncture. 6. The needle is inserted into the vein, bevel up at an angle of 15 to 30 degrees. 7. If the plunger of a syringe is pulled back too fast, the specimen may be hemolyzed. 8. Firmly anchoring the vein in needle insertion will avoid causing a hematoma. 9. Before bandaging the puncture site, you should examine the site for bleeding. 10. When using a winged blood collection set, you may collect blood into a syringe. 3 reasons for palpation of the vein. Determine the depth of the vein, the size of the vein, and the direction of the vein. 2 errors in test results that can be caused by prolonged tourniquet application. Hemoconcentration might cause high molecular weight analytes to have erroneous results. Hemolysis might occur, causing erroneously high potassium values.